For decades, therapists have been treating patients the same way you drive a car blindfolded at 70 miles an hour, adjusting the steering based on feel, intuition, the faint vibration of the road beneath the wheels. And what's fascinating is that this wasn't considered reckless. It was standard practice. The entire behavioral health industry operated on gut instinct while every other branch of medicine demanded data.
But 2026 changed everything. This year, the blindfold came off, and what providers discovered about their own performance. It's reshaping a $400 billion industry. It's time to understand this deeply.
To understand why measurement-based care suddenly became unavoidable, we need to look at what happened in January 2026. The Centers for Medicare and Medicaid Services finalized new rules that fundamentally rewired how behavioral health gets paid. Under the 2026 Medicare physician fee schedule, reimbursement now explicitly ties to demonstrated outcomes, not just providing therapy sessions, proving those sessions actually work.
The clinical evidence suggests this shift was inevitable. Post-pandemic, behavioral health exploded. Telehealth startups raised billions. Patient volumes surged 40% in 3 years. But here's the uncomfortable truth. Nobody could prove patients were actually getting better.
And payers noticed. Private insurers, Medicaid programs, large employers. They started asking a simple question. We're spending more than ever on mental health. Where are the results?
What this means for actual lived experience is profound. An estimated 340 million Americans have some form of mental health coverage, and the organizations treating them now face a stark choice: measure outcomes or lose funding.
The key players driving this transformation form an unlikely coalition. CMS and SAMHSA on the federal side, the National Committee for Quality Assurance, or NCQA, setting measurement standards, the American Psychological Association endorsing specific tools, and technology companies like Lucet Health building the infrastructure.
From a therapeutic perspective, the stakes couldn't be higher. Providers who can demonstrate reduced emergency room visits, shorter inpatient stays, and measurable symptom improvement will thrive. Those who can't face consolidation, contract losses, or closure.
The empirical findings indicate this isn't hypothetical. In the first quarter of 2026 alone, 3 mid-sized behavioral health organizations in the Midwest lost their primary payer contracts specifically because they couldn't produce outcome data. 2 have already announced mergers.
So, let's break down exactly how measurement-based care works, because the mechanism is surprisingly elegant once you understand it.
The core principle works like this. Instead of relying on a patient saying, "I feel better," or a clinician's subjective impression, you use standardized assessment tools at regular intervals. The same questions asked the same way every single session. Take the PHQ-9, the most widely used depression screening tool. 9 questions, each scored 0 to 3. Total score ranges from 0 to 27. A score of 5 to 9 indicates mild depression, 10 to 14, moderate, 15 and above, moderately severe to severe.
The healing journey often involves tracking these numbers over time. Patient comes in with a PHQ-9 score of 18. That's moderately severe depression. After 6 weeks of treatment, the score drops to 11. That's reliable improvement. You can see the trajectory.
But here's where it gets clinically powerful. If that score stays at 18 or worse, climbs to 21, the current treatment approach isn't working. The data screams, adjust now. Don't wait another 3 months hoping things improve.
And the research consistently shows this feedback loop makes an enormous difference. A meta-analysis of multiple randomized controlled trials found that patients receiving measurement-based care showed 3.5 times greater reliable improvement compared to treatment as usual.
From a neuroscience perspective, there's something even more interesting happening. Repeated tracking and visible progress creates a dopamine feedback mechanism. Patients see their numbers improving, which reinforces engagement with treatment.
The tools extend beyond depression. GAD-7 measures anxiety with 7 questions. PCL-5 tracks PTSD symptoms with 20 items. The BAM-R assesses substance use recovery. Each provides that same temporal resolution, the ability to see patterns over time that single measurements simply cannot reveal.
What the research consistently shows is that therapists, even experienced ones, systematically overestimate patient improvement by about 25%, and they miss deterioration in 5 to 10% of cases. The data catches what clinical intuition misses.
I find it hopeful that this isn't about replacing clinical judgment, it's about augmenting it. The patient and clinician review the data together, building what researchers call therapeutic alliance, like having a shared dashboard for the healing journey.
The origins trace back to Michael Lambert's patient-focused research in the early 2000s. His 2001 randomized controlled trials demonstrated that therapists receiving systematic feedback about patient progress achieve significantly better outcomes than those relying on judgment alone.
And now, 25 years later, that research is finally becoming standard practice. Lucid Health has already delivered over 14 million assessments through their Behavioral Health Index dashboard, real-time insights flowing to clinicians across the country. Let me paint a picture of what this looks like for an actual person. Sarah is a 34-year-old mother of 2 living in rural Kentucky, generalized anxiety disorder that's been disrupting her life for years.
Before measurement-based care, Sarah's treatment looked like this. Monthly therapy sessions where she'd describe how she felt. Her therapist would nod, offer coping strategies, and schedule another appointment. Progress was vague. "I think I'm doing a little better" became the refrain.
The wellness approach suggests we needed something more concrete. When Sarah's clinic implemented the GAD-7, everything changed. Her baseline score was 16, severe anxiety. Every session, she completed those 7 questions before meeting with her therapist.
After 4 weeks, her score dropped to 13, moderate improvement. But then something concerning happened. Week 6, her score jumped back to 17, higher than when she started.
Without measurement, that deterioration might have gone unnoticed for months. Sarah would have kept saying, "I'm managing," while actually spiraling. But the data flagged it immediately.
Her treatment team adjusted course, added a medication consultation, increased session frequency. Within 8 weeks, her GAD-7 dropped to 9. Mild anxiety, manageable. She returned to work full-time.
What this means for actual lived experience is profound. Sarah isn't an anomaly. The VA has piloted measurement-based care extensively, using the PCL-5 for PTSD patients returning from deployment. One veteran I read about had been in treatment for 18 months with minimal progress. PCL-5 tracking revealed his scores were actually worsening.
The clinical team switched therapeutic approaches, moved from talk therapy to prolonged exposure therapy. Within 4 months, his PTSD symptoms reached remission levels. The data revealed what years of subjective assessment had missed.
From a therapeutic perspective, there's also a destigmatization effect. Patients see their mental health as something measurable, trackable, improvable. Not a permanent character flaw, but a condition that responds to treatment, like managing diabetes or high blood pressure.
UConn Health ran a pilot program that scaled to 18,000 patients after the data proved its effectiveness. Better matching of patients to appropriate care levels, fewer people stuck in treatments that weren't working.
The recovery narrative shows this isn't just about individual healing. When parents stabilize, children thrive. When workers recover, communities strengthen, the ripple effects extend far beyond the therapy room.
But here's where we need to push back on the optimistic narrative, because measurement-based care faces serious obstacles that its proponents sometimes gloss over.
Let me be direct about the biggest one. Adoption remains shockingly low. Despite endorsements from the APA, SAMHSA, and major payers, fewer than 20% of behavioral health providers consistently use measurement-based care.
That's actually surprising to me because the evidence is overwhelming. 3.5 times better outcomes, reduced dropouts, faster identification of treatment failures. Why would clinicians resist something so clearly beneficial?
The reasons are more structural than philosophical. First, workflow disruption. Administering assessments, entering data, reviewing dashboards, it adds time to already packed schedules. Clinicians in community mental health centers often carry caseloads of 80 or more patients.
Second, and this is the hidden pattern the industry doesn't like discussing, there's genuine fear about how the data will be used. If a clinician's patients consistently show poor outcomes, will insurers use that to deny claims? Will employers use it to justify terminations?
I hadn't thought about it that way before, but that surveillance concern is legitimate. Electronic health records weren't designed for this kind of continuous outcome tracking. The infrastructure gaps are real.
There's a philosophical objection that deserves serious consideration. Are we medicalizing normal human experience? A PHQ-9 score of 8? Is that clinical depression requiring treatment, or just someone going through a difficult period?
The wellness approach suggests we need nuance here. These tools measure severity, not diagnosis. A score of 8 doesn't automatically mean someone needs medication. It provides information for collaborative decision-making.
But I need to sit with that for a moment, because there's a financial incentive to expand the treatment population. More diagnoses mean more billable services. The tools themselves are neutral, but the system they operate in is not.
And then there's the equity question that keeps me up at night. Small practices serving low-income communities often lack the technology infrastructure for sophisticated dashboards. If measurement-based care becomes mandatory for reimbursement, do we inadvertently eliminate the providers who serve the most vulnerable?
The empirical findings indicate this isn't hypothetical. Rural mental health clinics already operate on razor-thin margins. Adding technology requirements without corresponding funding support could accelerate the very access crisis measurement-based care is supposed to address.
Let me push back on that for a second, though. The alternative, continuing to fund treatments with no accountability, hasn't served vulnerable populations either. People cycling through ERs without progress, receiving care that doesn't work.
That's the genuine tension at the heart of this transformation. Accountability versus access, data versus privacy, standardization versus personalization. None of these are fully resolved. So where does this go from here? Let me offer 5 evidence-based predictions for behavioral health over the next 18 months. First, consolidation will accelerate dramatically. By mid-2027, I expect at least 30% of independent behavioral health practices will have merged, been acquired, or closed. The organizations that invested early in measurement infrastructure will absorb those that didn't.
From a therapeutic perspective, that consolidation has mixed implications. Larger organizations can afford better technology, but they also tend towards standardization that may not serve every patient's unique needs.
Second, AI-enhanced dashboards will become standard. We're already seeing platforms that flag not on track patients 15 to 25% faster than human review alone. Pattern recognition across thousands of cases identifies warning signs clinicians might miss.
The healing journey often involves catching problems early. If AI can identify a patient heading toward crisis before it happens, that's genuinely valuable. But it also raises questions about algorithmic bias and who trains these systems.
Third prediction. Social determinants will integrate into measurement. The current tools focus primarily on symptoms, but housing instability, food insecurity, social isolation, these factors profoundly influence mental health outcomes. NCQA's person-centered measures, funded by the Hartford Foundation, are pushing in this direction.
What I find hopeful is the recognition that mental health doesn't exist in isolation. Treating anxiety while ignoring that someone can't afford their rent, that's incomplete care. Measurement needs to capture the whole person.
Fourth, privacy regulations will lag behind data collection. This is the uncomfortable prediction. We're accumulating unprecedented amounts of sensitive mental health data. The regulatory frameworks protecting that information were designed for a different era.
And fifth?
Fifth, and this connects back to where we started. The blindfold will come off for patients too. Consumer-facing dashboards showing your own treatment trajectory will become expected. Demand for transparency will flow in both directions.
Breaking down the stigma around this means treating mental health like any other health condition. You can see your blood pressure trends. Why not your anxiety trends?
The 2026 Medicare rules previewed outcome-tied funding. By 2027, I expect similar requirements across Medicaid and major commercial insurers. The era of unaccountable behavioral health spending is ending.
The question isn't whether measurement-based care will become standard. It's whether the transition happens equitably, with privacy protections, in ways that serve patients rather than just payers.
So, here's what we've learned. For decades, behavioral health operated on intuition in an evidence-based world. The 2026 pivot to measurement-based care represents the industry finally catching up.
The clinical tools exist: PHQ-9, GAD-7, PCL-5. The evidence is overwhelming. 3.5 times better outcomes when data guides treatment. The infrastructure is building, with companies like Lucid already processing millions of assessments.
But the transformation isn't purely technical. It's cultural. Clinicians learning to trust data alongside intuition. Patients engaging as partners in their own measurement. Systems redesigning around accountability.
What this means for you listening right now is simple. If you're in therapy, ask about measurement. What tools does your provider use? Can you see your own trends? The data belongs to you.
And if you're not seeing progress, if sessions feel like they're going nowhere, the numbers might reveal what conversation cannot. Measurement-based care isn't about reducing humans to data points. It's about ensuring the care you receive actually works.
The blindfold is coming off. The question is whether we use what we see to drive toward genuine healing.
This is exactly the kind of transformation we explore every day at Deeply, stories that go beneath the surface, that unpack the systems shaping our lives.
New episodes drop daily across science, technology, health, and society. Follow Deeply wherever you get your podcasts and join us as we make sense of a complex world.
Until next time, take care of your mind.
With proof.